Next topic, filling of the bladder and bladder wall tone, the cystometrogram. There are some approximate changes in intravesicular pressure as the bladder fills with urine. When there is no urine in the bladder, the intravesicular pressure is about 0, but by the time 30 to 40 ml of urine has collected, the pressure raises to 5 to 10 centimeter of water. Additional urine 200 to 300 ml can collect with only a small additional rise in pressure. This constant level of pressure is caused by intrinsic tone of the bladder wall itself. Beyond 300 to 400 ml, collection of more urine in the bladder causes the pressure to raise rapidly. Superimposed on the tonic pressure changes during filling of the bladder are periodic acute increase in pressure that last from a few seconds to more than a minute. The pressure peaks may raise only a few centimeters of water or may rise to more than 100 centimeters of water. These pressure peaks are called Micturition waves in the cystometrogram and are caused by the Micturition reflex. Next major topic, Micturition reflex. One can see that a bladder fills, many superimposed Micturition contractions begin to appear, and they are the result of a stretch reflex initiated by sensory stretch receptors in the bladder wall, especially by the receptors in the posterior urethra when this area begins to fill with urine at the higher bladder pressure. Sensory signals from the bladder stretch receptors are conducted to the sacral segment of the cord through the pelvic nerves and then reflectively back again to the bladder through the parasympathetic nerve fibers by way of the same nerves. When the bladder is not partially filled, those micturition contractions usually relax spontaneously after a fraction of a minute. The detrusor muscles stop contracting and pressure falls back to the baseline. As the bladder continues to fill, the micturition reflex becomes more frequent and causes greater contractions of the detrusor muscle. Once the micturition reflex begins, it is self-regenerative. That is, initial contraction of the bladder activates the stretch receptor to cause a greater increase in sensory impulses from the bladder and posterior urethra, which causes a further increase in reflex contraction of the bladder. The cycle is repeated again and again until the bladder has reached a strong degree of contraction. Then, after a few seconds to more than a minute, the self-regenerative reflex begins to fatigue. Thus, the micturition reflex is a single complete cycle of progressive and rapid increase of pressure, a period of sustained pressure, return of the pressure to the basal tone of the bladder. Once the micturition reflex has occurred but has not succeeded in emptying the bladder, the nerve elements of this reflex usually remain in an inhibited state for a few minutes to 1 hour or more before another micturition reflex occurs. As the bladder becomes more and more filled, micturition reflex occurs more and more often and more powerfully. Once the micturition reflex becomes powerful enough, it causes another reflex, which passes through the pudendal nerves to the external sphincter to inhibit it. If this inhibition is more potent in the brain than the voluntary constrictor signals to the external sphincter, urination will occur. If not, urination will not occur until the bladder fills still further and the urination reflex becomes more powerful. Then next topic, facilitation or inhibition of micturition by the brain. The micturition reflex is an autonomic spinal cord reflex, but it can be inhibited or facilitated by centers in the brain. The centers include strong facilitative and inhibitory centers in the brainstem, located mainly in the pons, and several centers located in the cerebral cortex that are mainly inhibitory but can become excitatory. The micturition reflex is the basic cause of micturition, but the higher centers normally exert final control of micturition as follows. The higher centers keep the micturition reflex partially inhibited except when the micturition is desired. The higher centers can prevent micturition even if the micturition reflex occurs by tonic contraction of the external bladder sphincter until a convenient time presents itself. When it is time to urinate, the cortical centers can facilitate the sacral micturition centers to help initiate a micturition reflex and at the same time inhibit the external urinary sphincter so that urination can occur. Then voluntary urination is usually initiated in the following way. First, a person voluntarily contracts his or her abdominal muscles, which increase the pressure in the bladder and allows extra urine to enter the bladder neck and posterior urethra under pressure, thus stretching their walls. This action stimulates the stretch receptors, which excites the micturition reflex and simultaneously inhibits the external urethral sphincter. Ordinarily, all the urine will be emptied, with rarely more than 5 to 10 ml left in the bladder. Now we are going to learn abnormalities of micturition. First, atonic bladder and inconsistence caused by the distortion of sensory nerve fibers. Atonic bladder and inconsistence caused by the destruction of sensory nerve fibers. Micturition reflex contraction cannot occur if the sensory nerve fibers from the bladder to the spinal cord are destroyed, thereby preventing transmission of stretch signals from the bladder. When this happens, a person loses bladder control despite intact efferent fibers from the cord to the bladder and despite intact neurogenic connections within the brain. Instead of emptying periodically, the bladder fills to capacity and overflows a few drops at a time through the urethra. This occurrence is called overflow incontinence. A common cause of atonic bladder is crush injury to the sacral region of the spinal cord. Certain diseases can also cause damage to the dorsal root nerve fibers that enter the spinal cord. For example, syphilis can cause constrictive fibrosis around the dorsal root nerve fibers, destroying them. This condition is called tabs dorsalis, and the resulting bladder condition is called tabetic bladder. Then, automatic bladder caused by spinal cord damage above the sacral region. If the spinal cord is damaged above the sacral region, but the sacral cord segments are still intact, typical micturition reflex can still occur. However, they are no longer controlled by the brain. During the first few days to several weeks after the damage to the cord has occurred, the micturition reflexes are suppressed because of the state of spinal shock caused by the sudden loss of facilitative impulses from the brainstem and cerebrum. However, if the bladder is emptied periodically by catheterization to prevent bladder injury caused by overstretching of the bladder, the excitability of the micturition reflex gradually increases until typical micturition reflex return. Then periodic but unannounced bladder emptying occurs. Some patients can still control urination in this condition by stimulating the skin, like scratching or tickling in the genital region, which sometimes elicits a micturition reflex. Then uninhibited neurogenic bladder caused by lack of inhibitory signals from the brain. Another abnormality of micturition is the so-called uninhibited neurogenic bladder, which results in the frequent and relatively uncontrolled micturition. This condition derives from the partial damage in the spinal cord or the brainstem that interrupts most of the inhibitory signals, therefore facilitates impulses passing continuously down the cord, keep the sacral centers so excitable that even a small quantity of urine elicits an uncontrollable micturition reflex, thereby promoting frequent urination.